So when somebody I know that I'm worried about sepsis, immediately what I do is I pan culture them. I get a urine culture if I'm worried about urosepsis, blood culture, sputum culture, worried about pneumonia, whatever it is. I give 1 to 2 liters of lactated ringers, not normal saline, because there's data for normal saline chloride affecting the kidneys. I stop there. I'm very broad with my antibiotics. I check a lactate just to be in compliance with the guidelines. And then I try to do source control as soon as possible. Now, after all this, assuming a healthy patient, right, it's going to vary depending on who your patient is. If my MAP is less than 65, I start norepinephrine immediately. That may be within 45 minutes to an hour. In fact, they may be on the wards and they may only have a peripheral IV. I may place the peripheral IV myself in the antecubital fossa, in a big vein, and start the norepinephrine myself at this point immediately. Ideally, you want to give things like norepinephrine through a central line in case it extravasates, it doesn't cause damage. Although there is a study out there looking at the effect of norepinephrine given peripherally versus centrally, and it found no major bad outcomes. But in that study, the patients who got it given through a peripheral IV, they confirmed that the catheter was truly in the vein using an ultrasound in the big antecubital region. If their MAP is also low, I place an arterial Arline in the radial artery. Now, if my MAP is still low and I've reached 10 mics per minute of norepinephrine, I start vasopressin. Again, thinking ahead in that post hoc study where there was a mortality benefit dealing with the acute kidney injury effect. If my MAP is still low after that, I start stress dose steroids and I do my own